Live. And greetings everybody watching live from Subang Jaya Medical Center. My name is Awunting, and with me is Dr. Siva Ariyaratnam, consultant orthopedic surgeon. And today we are having some exciting presentation from Dr. Siva on total knee replacement surgery, or TKR. And this is totally outpatient, walking, ambulating, and home the same day as surgery. So I just want to take you through some housekeeping slides first, and we would like to invite you to ask questions using Slido. So to ask your questions, visit slido.com and enter the code 4305804, or you can just scan this QR code. It will take you to Slido and into our event page. And feel free to ask questions, but we will take your questions only at the end of Dr. Siva's presentation. Okay. I know some of you are already asking in Facebook. Yes, there will be, this event is claimable for CBD points. You will get a point. We will display the code for claiming CBD points at the end of the Q&A. Okay, so the talk first and the Q&A, and then we will display the points in this blank slide here. Okay. So be patient. We will give you ample time to scan the point. So without further ado, I'd like to invite Dr. Siva to give his exciting presentation on fast-track total knee replacement. So over to you, Siva.
Thanks, Alan. Good afternoon, everyone. So I think some of you might have heard this talk a couple of weeks ago in a live broadcast. It's going to be pretty much the same, but I'm going to be touching on a little bit of technicality. So basically, I know there's a lot of euphoria on daycare knee replacement, but there are very stringent criteria for patients who actually qualify. For now, I don't tell a patient, look, would you like to do this as a daycare procedure? It's usually by request. So patients who usually do request are patients who have had one knee done before and who know the drill and know what it involves. And also there are some criteria that they need to fulfill in terms of comorbidities and where they're living and other things. So a little bit about myself. So I'm fellowship trained in hip and knee replacements. I spent time in Sydney, Australia, where I learned some minimally invasive techniques and also something very exciting, early mobilization. And then I also did a fellowship in one of the foremost institutions in North America about 12 years ago. And I'm a joint replacement trainer after the pandemic, and then after that, slowed down a little bit. A few things that I've done, I pioneered patient-specific instruments in total knee replacement, I think in 2010 when I came back from overseas. I've done the first generation Oxford UKA, and I've also recently done the specific patellofemoral partial knee replacement, first case in Malaysia. So I'm going to take a rather unconventional approach. I'm going to talk about complications, because this is the way I dealt with improving outcomes of knee replacement. So 15, 16 years ago, when I was doing it in a big way, I always was very perplexed by and obviously worried by the complications that we encounter with knee replacement. So to arrive at a point where I would be brave enough to allow a patient home the same day, obviously I would have had to address all these complications, and it's taken a good, I would say a good 10, 12 years to sort of smooth things out to decide fit to go home on the day of surgery. So I'm going to deal with the complications in terms of complications that occur in the first week, month, year, and beyond the first year of surgery. So obviously the most important for daycare knee replacements would be complications that occur in the first week. So you're going to deal with complications such as pain, stiffness, bleeding, pain, stiffness, bleeding, wound breakdown, nausea, vomiting, and other complications that occur within the first week. And then in the first month, we have complications such as pain, stiffness, infection, DVT, pulmonary embolism, and others. And then there are complications that occur in the year and beyond 1 year from surgery. So for the purpose of today's talk, I'm mostly going to be dealing with complications that occur within the first week. So what are these? So the first issue to overcome is pain. If any one of you has gone through a knee replacement or had a relative who's gone through a knee replacement, I think the most overwhelming thing that you would probably remember is the pain. When I was junior doctor and I was in the ward, I used to dread the day my consultants used to do knee replacements, because every hour at night the nurses used to call and say, "Doctor, the patient stuck it." So I had to come in and give them some injections of painkillers. My own patients in the early years, I had a lady, when we were working in the government hospital, everything was free. Implant was by JPA. And she had one knee done, and I followed her up to a year. And then when I asked her when she wanted to do the other knee one, which was already paid for, she said, "Doctor, thank you very much, but the pain was unbearable. It was worse than childbirth. So I'm very grateful for my first knee, but I'm not going to have the other knee done." So how do you justify putting someone who's coming for an operation to reduce pain, to put them through that much of pain, even though it's for a very short period of a few months or a year? So how do we deal with pain? So first of all, I think the most important thing is the type of anesthesia. So the gold standard of anesthesia for joint replacement used to be combined spinal epidural. So the epidural catheter was left in for about 48 hours. It was supposed to give pain relief, but the patient was not supposed to have motor blockage. But often it was a very fine line between muscle power and pain management. And usually we never quite got it right. So patient was most of the time immobile in bed. And after 2 days, when you even remove the catheter, patients were in a lot of pain because the breakthrough pain, because they're not on any oral medication. And so that was not ideal, and we had to search for better pain management protocols. The first thing that I learned in my first fellowship when I was in Australia was to do a knee replacement through a different incision. So the incision in front of the knee is the same, but once you go in, 90% of surgeons or 95% of surgeons they still use a midline medial parapatellar approach. So the cut is right through the quads muscle, which is what you need to stand up and walk. And obviously, even though that's sutured at the end of the procedure, it's going to be very painful. So what I learned to do is I learned to do a muscle sparing approach, such that the cut was actually through the medial to the patellar tendon, but beyond the patella, superiorly or proximally, I did a subvastus approach where the muscle was actually elevated off instead of being cut through for the surgery. So that resulted in patients mobilizing early and without much weakness and with less pain. And then we started using general anesthesia with multimodal anesthesia, including periodical injections and oral combinations. So what are these periodical injections? And so this was popularized, or rather published in a randomized control trial from the institution that I work in Canada. So a combination of medications, not only what medications, but also where and when to inject them during surgery. So with these injections and a general anesthetic, we were able to reduce the pain to a significant level, such that the patient had less pain after surgery. So from then we also used oral combinations of medications post-op, such that there was less reliance on opioids and less reliance on intravenous medication. So this is a video of a patient walking around about 6 hours after surgery, and this is not recent because this is from the previous hospital that I worked in which is in Gleneagles, Penang. I left Gleneagles, Penang at the end of 2012. So this video is at least about 10 years old, and as you can see, the patient is actually walking without the use of his walking frame about 6 hours after surgery. So all this I started doing after I came back, and so that was my early achievement. But then there are a lot of other things that we needed to address. Then another early complications that can occur within the first week is risk of stiffness. Now that's very dependent on surgical technique. Surgical technique, basically, one is the minimally invasive muscle sparing approach, and it's also dependent on the ligament balancing. Very rarely is the patient stiff because of an intrinsic problem with the patient. Though it's not impossible, but it's rarely an intrinsic problem with the patient itself. So then, if you have stiffness, patient needs manipulation under anesthesia, take patient practice better. We need to use CPM machine for mobilization. This obviously will not allow patients to go home within the first week of surgery. But I think I've sort of developed a technique where I've not used the CPM in a total knee replacement, at least for as long as I've been in SJMC, which has been for the last 10 years. The other complications is complications of bleeding and wound breakdown. Now, how do you prevent, or how do you consistently prevent bleeding so that we are confident enough to send patients home on the same day? Number one is skin closure technique. So over the years, from input that I've had in my fellowship and I think that I've developed on my own, I've kind of developed a skin closure technique which allows, which reduces the risk. And I'll show you how I actually mobilize my patient, and this would even withstand mobilization like I would do. Then there are other things like how do you secure hemostasis, what vessels you cauterize. All this is surgical technique dependent. The question of whether to use the drain or not to use the drain, whether to use a tunicate, and how much transfusion. So I think I intend to publish soon on the fact that if any patient with starting hemoglobin of higher of 12 and above has so far not needed transfusion in my experience in the last 10 years. In fact, even for bilateral knees, if they have a starting HB of 12 and above, they have not required transfusion with proper blood management. So in the old days, we used to do surgeries and we used to put patients on knee immobilizers like this for up to 48 hours so that we don't allow them to bend. And the reason why we didn't allow them to bend because we were afraid of bone breakdown, because our skin closure techniques are probably not very good. But this is how I bend patients now. So this is about a couple of hours after surgery. This is again a video from 10 years ago when I was not yet working in SJMC. So obviously skin closure would have to be much more robust to be able to mobilize patients like this. Now the other complication is the complication of nausea and vomiting. This is something that's really beyond my control most of the time. Of course, we give all patients antiemetics, but this is one of the, in the last 5 years, this has been my biggest issue with prolonged hospitalization. There are patients who come out of theatre with very little or no pain, but who've got very bad nausea and vomiting, which takes about 48 hours to control. So obviously, we're not going to be able to send this patient home. And it's difficult when you cannot predict this, because the patient who comes in and says, I want to go home on the same day, who starts vomiting after surgery, would suddenly have to derail her plans or his plans just because of vomiting and nothing else. So this is something that's very dependent on anesthesia. I'm grateful to work with some very good anesthetists here in SJMC who have helped pretty much reduce the risk of this occurring. The other complications, as you all know, heart attack, stroke, amputation, death. Thankfully, with a very stringent preoperative assessment, we have not had this happen at least in the last 10, 15 years that I can remember. I've had a few near misses where patients say, never mind, doctor, it's just a mild heart problem, do you mind just letting me do it? But surprisingly, even parents or doctors, but I think by being a bit hard-headed and insisting that patients have their preoperative assessment, especially for bilateral needs, I've been able to pick up one or two who could have potentially ended up in trouble. Now, complications that occur in a month really don't matter when you're doing a daycare or a short-stay knee replacement, except for two, which would be deep vein thrombosis and pulmonary embolism. So now, if you look at this paper, this is published in the GBJF from University Malaya Medical Center. Basically, they found that in a short span of time, over a period of 2 months, they had 3 patients who had postoperative pulmonary embolism. That we were of the opinion, first believe that this complication is rare in Asian patients, but in this study, patients, they found that 62% of them had deep vein thrombosis on a venographic study. And if you look at knee replacements alone, 76, which means that 3 in every 4 had a deep vein thrombosis. So this is an extremely high incident, which I think we need to all take note of. So this is a paper which I think was a very significant paper when I was working in Sydney. This was published in 2008 in the Australian New Zealand Journal of Surgery. Basically, what we showed is that the surgeon whom I worked with, he used to initially mobilize patients at 48 hours after surgery. But with a new protocol of using muscle sparing approaches, like I mentioned before, and periodical injections, he was able to walk patients within 24 hours, so the morning after surgery. So when I did a fellowship and I asked him if there's anything that I can start research, because it's not a very big research or publishing guy, but he said, well, I think that ever since I started walking my patients within 24 hours, we've had less. The protocol in Australia was patient needs to be shipped out to a rehab center at about 48 hours. And so before they do that, they do a venogram on all patients in that particular center that I worked in. So we actually looked up the 50 patients prior to this, to the new method of early mobilization and 50 consecutive patients from the time this was introduced. The good thing was the nurses, when they walked the patient, they wrote the exact time, the physio wrote the exact time that the patient walked, and also with an exact measurement of the distance that the patient walked. So when we looked at this 50 from before and after, we found that the incidence of DVT was statistically significantly lower in the group that mobilized at 24 hours after surgery rather than 48 hours after surgery. So this proves that probably we should revisit the concept that epidural analgesia was ideal for knee replacement surgery, where patients actually mobilized at about 48 hours or even 72 hours after surgery. And another thing that if a patient walked, if you look at patients who mobilized 24 hours, the patient walked at least 5 meters after surgery within 24 hours. He was lower than those that walked less than 5 meters after surgery within 24 hours. So, patients mobilized and the degree of mobilization. This paper has been, until this paper was published, it has never been proven that early mobilization, everybody mentioned early mobilization reduces the risk of DVT, but this was the first objective evidence that early mobilization actually reduces the risk of DVT, and this has been recently checked. It's been cited at least 150 times. Now, if you look at just an example, I've been walking patients. I've been discharging patients with an overnight stay or 2-night stay for as long back as 2014. So this is a patient, a 60-year-old female. She was from Sakin Chan. So this is the same patient. She had her first knee, which was her left knee, on the 28th of April, and she stayed 2 nights. The only complication was hypertension. And then about 9 weeks after the first knee, she actually came in for her second knee. And this time she only stayed 1 night. Now the hospital protocol is that if you do a surgery, the patient needs to be admitted at least 6 to 8 hours before surgery. So I admitted this patient in the morning. Operation was done at 1:30 p.m. In the evening after rounds, during rounds, I used to make the patient walk myself. At the time, about 6 or 7 o'clock in the evening. So patient walked the night, and then the next morning, patient would have climbed stairs with the physios and then home by the afternoon. So essentially, it was 24 hours between the start of the surgery to the time of the discharge, but patient stayed overnight. So again, this is a 71. This is another case where there's a 71-year-old man with a lot of comorbidities, but his wife was a general practitioner, and she was comfortable in taking him home with 1 night stay. The funny thing is, he was very afraid of the surgery, so he said he was going to stay for a week. And then the next morning, he said, you know what, it's the eve of New Year, so it's bad luck to stay in the hospital and I should go home. So on the 31st of December 2019, he left and went home. So if we look at my first official daycare, now why I'm saying official, because to be able to do daycare surgery, the first thing, our previous CEO, who is very familiar because she's been abroad and she's had evidence of our talks of this being done, is to have a home care nursing team. So we only got a home care nursing team officially around about August last year. And so we came across this patient in November who wanted to have a daycare surgery. So what I usually tell my patients to request for daycare, I tell them, look, don't put the pressure of making that decision now. We will admit you as an inpatient in the inpatient ward, not in the daycare ward, and then we will reassess you at 5 o'clock. And if both you and I are happy with your progress and think that you can go back, then we will let you go. So this lady was admitted around 9, surgery started about 9:30. When I visited her at about 2 p.m., she was already comfortably walking around the bed with a walking frame. And then when I saw her again at 5, my physiotherapist had come prior to that, about 4 o'clock. She walked the patient along the corridor, up the back stairs in the third floor surgical ward, which is a long flight of stairs. and she had gone to the toilet and had come back, packed all her stuff, changed her clothing, then sitting on the bed waiting for me to send her home. So there was no pain, there was no oozing, X-rays were done here when I saw them at 2 p.m. And so I called the daughter and the husband because they were still MCO and told them, look, she wants to go home. Are you comfortable with that? They were very comfortable. And so they took her home. So now what are the protocols? I need to have a motivated patient. So I never burden the patient with this thing of, hey, you want to, help me increase my statistics or that never happens. It's got to be on a request basis. You request, you would have to come with your family, you have to have a supportive family who are willing to drive you home. You would have to have limited comorbidity, low BMI, patients living within reach of home connect. So staying in Kinchan or Semenye, unfortunately, no. Patients who are fairly strong, despite very severe arthritis, which is not does not preclude being able to go home the same day, but if there's someone who's very weak, who's got very little muscle power, then probably not. Patients have to be able to walk and bend their knees to at least about 90 to 100 degrees before I will let them go home. And the decision to go home will be made bilaterally at around 5 p.m. So for everybody else, they get what's called a fast-track knee replacement. So fast-track knee replacement to reduce the incidence of deep vein thrombosis, to improve the whole experience. So previously I used to tell patients, you can get your second knee done after 3 to 4 months. Some never come back, and I'm talking about 10 years ago. In the last 6, 7, 8 years, I've never had patients who staged their knee replacement, none that I can remember, who did not come back to get the other knee done. And I've had patients come back requesting for the other knee done at 2 and 3 and 4 weeks because they felt that they had recovered and they were in much less pain. But every now and then we get patients who do have pain, breakthrough pain. So it's not something that's so reproducible. If it was so easy, we would have been doing it many years ago. Right now, daycare knee replacements are done in some centers in Europe, and even in some of the centers that I've contacted or whom I've read are doing it, would do it for probably about less than 10% of their patients. In India, they do them for some patients for partial knee replacement. In the US, some centers, because they're required by insurance, so they've got a very strong home connect team and, home physios, home rehabs and stuff like that, which are within reach of the patient. So what is the future direction of knee replacement? I actually wrote this around 2011, and I wrote into the Star all by myself, and to my surprise, it was accepted. It's basically something talking about, in an article 11 years ago, talking about advances in knee replacement and the way that it's going to move forward. I think somewhere here I mentioned that patients will be able to walk morning after surgery, which was what I brought back from overseas. But I think a lot of what's in this has changed now. The other question is, do we do a knee replacement for all patients with arthritis? Absolutely not. Patients nowadays have a very high demand. If you do a knee replacement, you cannot jump or run. So when I worked overseas, patients could ski, patients could surf, but you cannot run and you cannot jump. So if someone who has arthritis, who's in significant pain, but runs and then comes back, takes an narcoxia, wraps their leg, ices it, takes a swig of whiskey, all these sort of things I've heard. If you tell them, come in for a knee replacement, I'll take away your pain, but you will not be able to run, they will say go to hell, because I need to run. Even though I'm 60 or 70, I have to run, and it's okay, I'll just manage with pain. So can you do arthritis? Can you do a surgery for patients with knee arthritis who want to continue doing high impact activities? So yes, knee replacements, all patients who have comorbidities, who are not good at a lot of other things to do, injections, and this is for 9 month operation. The last thing you have to do is do an operation and send a patient who is otherwise still very much alive back home in a box. So no surgery for patients who are not fit. In terms of, okay, so this is something that I do for active patients who have got not so much stage 4, but stage 3 almost bone on bone, who are runners, who are footballers, or who want to continue to So what is high-level observation? So this is a patient with bilateral medial arthritis. You can see the joint line, joint space is narrowed in both his knees. And if you divide it long leg X-ray, which I do for all my patients, and if I draw a line from the center of the hip to the center of the knee, so if I do a line from the center of the hip to the center of the ankle, this line in the normal patient should pass through the center of the knee. So what happens when the line passes through here? Now, when your line passes through the center of your knee, the distribution of weight to both sides is the same. But when you have a line that passes here, then obviously most of the pressure actually goes to the inside of the knee. So what if I can do something to send the axis of the weight bearing through the lateral aspect of the knee, right? So how do I do that? So this, and this is what's done. So what's actually done is a cut is made on the proximal cortex of the tibia, and then this is opened up, and then in this patient I use a wedge bone graft. In most patients I don't. So there's a space here, and then we use an implant. And look at what happens to the joint line. So the joint line actually opens up. Now, if you look at the axis actually passes a little bit through the outside of the knee, such that most of the pressure now goes through the outside, which has good cartilage. And this would probably buy the patient another 10 years. Now, this obviously, when you tell patients you're going to cut the knee, they freak out. But then if you think about it, even with a knee replacement, you're cutting the knee, but you're sacrificing the joint. You're replacing the joint such that the joint, there's no turning back. In this surgery, the joint is actually not cut at all. So the patient has their own joint. In about a year or two from surgery, this implant can be removed, and you have a normal looking knee, which they can use for a further 10 years. Now, this is not for everyone. It's only for patients who would say that, I'm in a lot of pain, but I will not sacrifice the activities that I do. And so that is when we do things like this. This is that patient with a bilateral HTO walking without support at about 31 days after surgery. So by about 4 to 6 months after about the rehab, they should be able to go back to fairly high impact activities. Now, another niche surgery which I do, which is quite rare, is a patellofemoral knee replacement. So I do a bunch of this, maybe 1 or 2 cases a year, very, very low, small indication, until a point where the implant company that used to sell the implants took them off because they say, I'm the only one using it. It wasn't economically viable for them to sell it. But now with robotics, I've been able to do them again after a span of maybe a break of about 3 years. So here, the tibiofemoral joint is actually okay, but the patient only has arthritis in the patellofemoral joint. You can see here, there are lots of subchondral or cysts here, as well as in the patella side, and these two bones are actually rubbing. Now, and similarly here, you can see a lot of subchondral cysts. You can see good cartilage here and here, but zero cartilage in this space, and the bone is rubbing. So these patients typically have no pain when they are walking on level ground in a straight line. When they walk downstairs, when they do twisting, turning activities like dancing, when they try to get out of a chair, they have excruciating pain in the front of the knee, but everything else is okay. they are fairly young people. So this lady is a banker. She's 50-something years old. She has got no pain on walking on level ground, but she's got to be very careful when she turns, goes down a slope, when she does anything of that sort. She has very excruciating pain because of her bones are rubbing. And another thing is that she has a deficient PCL. She doesn't have a PCL. So when you have a deficient PCL, your femur tends to be translated forwards. So when your femur is translated forwards, especially when you're going down a slope, the joint reaction forces in the patellofemoral joint is extremely high. And so this actually worsens the pain. So to do a total knee replacement in this patient who has got an otherwise okay tibiofemoral joint would be an overkill. These sort of patients would not appreciate a full knee replacement because they still have intact ligaments in their knee. If you take off all the ligaments and put a mechanical component in, they would feel something foreign in their knee, and they've not reached the stage where they have pain, where they appreciate that sort of surgery. So they would not be happy customers. So for this patient, try injections first, physiotherapy for several months, and then when everything else failed, I spoke to her about doing a patellofemoral replacement, and she's been seeing me for all sorts of treatments for the last 6 months, including an arthroscopy. But I did tell her when I did the arthroscopy, she had a minor lateral meniscus tear. I told her that I don't think my arthroscopy is going to give you any pain relief because I think your predominant pain is coming from your patellofemoral joint. But I think she was at a point where she was in so much of pain that she said, look, I want to get it done so that I know, at least I know that I tried something. So we did an arthroscopy. So that was good because I could take a lot of pictures for her and show her what exactly was going on. Cleaned up the meniscus tear, and finally she agreed to do a partial patellofemoral. So here, as you can see, only the patellofemoral joint has been replaced. The tibiofemoral joint space is pristine. She's got very good tibiofemoral joint space. Yes, she has some osteophytes, but nowhere near the point of getting a knee replacement done. And 3 weeks after surgery, she's been back to swimming, and about 6 weeks after surgery, back to dancing. Very happy with the knee, despite the fact if you look here, you'll find that the femur is actually it's a little bit further in front than it usually is. So the joint, and that's the reason why the joint reaction forces in the patellofemoral joint are high. So with robotics, we can also do these very specific partial replacements that require a very high level of accuracy. So robotic surgeries, the outcomes are very good. Sorry, problem with the screen. What happened? Okay, sorry about that, technical hitch. As I was saying, with robotic surgeries lead to superior outcomes because the alignment is a knee replacement. One very prominent knee replacement surgeon once said a knee replacement is a soft tissue surgery with incidental bone cuts, and I think that holds very true. So we always look at the X-rays and say, "Oh, X-ray looks fine," but patient has pain and patient has instability, and that's got a lot to do with soft tissue balancing. So no amount of accurate X-rays or even robotics will help you with soft tissue balancing. That's something that's a function of the surgeon. But what robotics help with is to accurately give you the cuts that you want, and also in instances where you need to recut to rebalance the knee, you can do repeat cuts at accuracies of 1 millimeter, which is very difficult to do when you're doing conventional surgery. So with these improved cuts, you would expect improved longevity with robotic surgery and lower complications. And as I said, we are able to more accurately do niche forgotten partial surgery. Now, one of the problems with the patellofemoral replacement that I showed you is that sometimes, especially in Asians, the implants don't fit so well. So if you open up the knee and then find that, oops, this implant doesn't fit this patient, that would be a problem, and that would never be a problem with robotics, because when the knee is scanned into the robotic system, the exact size of the femur, the tibia is known by the robot, and so when we measure, we're able to see the exact size and placement of these components. Will they reduce risks and complications? Well, as there's nothing that is 100% wonderful. So robots themselves, just as in the past, computer navigation have their own set of risks, but it's our duty as a surgeon to sort of manage those risks and reduce it. And will robotic surgery assist with daycare? In a small part, yes, but a lot of it is still dependent on early mobilization or daycare. Let's say early mobilization. Early mobilization is really very dependent on surgical technique rather than robotics. Robotics is just there to improve the longevity of implants, or making the knee last longer and longer, because patients are getting younger and more physically demanding. So robotics will help patients with implants that can last longer. So I'll leave you with this. Here's a patient with a severe bilateral knee osteoarthritis. I think some of you might have seen this video. So this patient, this is her 48 after bilateral knee replacement, and this is her at a month after bilateral knee replacement, and she's now about 7 years out from surgery and doing well. So there's no need to suffer if you have severe osteoarthritis, and this also reduces quality of life. When patients come and ask me, "Doctor, what if I don't do the surgery?" So I won't tell them things like, you'll be in a wheelchair and stuff like that, because all that is not true. You will probably never be in a wheelchair, but you will get significantly immobile. If someone comes and says, "Hey, let's go to the mall, let's go overseas, or let's go for a trip," you probably wouldn't want to go. You probably wouldn't want to follow your family to the mall or for dinner because you're in significant pain. And that reduces your quality of life and reduces your mobility. So if you're fairly young, otherwise healthy, and the only thing slowing you down is a bad knee, then I think our patients deserve a chance at getting their knee replacements done, and hopefully we can together improve their quality of life. Thank you.
Okay, thank you very much, Shiva, for the enlightening talk. I think it's given great insight on advancements in total knee replacement, especially early mobilization, rehabilitation, and so on. So we'd like to invite questions from the floor. You can use Slido, all right? So you can join us at slido.com, and so far there are no questions yet. Or if you're watching on YouTube or Docs Facebook, you can use the comment section to ask any questions. Maybe I can kick off, Siva. You said that early ambulation will reduce the risk of knee pain thrombosis. So in your practice, if they care thing, will you still give anticoagulation prophylactic?
I give anticoagulants for all patients. So now, early mobilization doesn't preclude the use of anticoagulants. So I anticoagulate all patients, and Alan, we've had a shared patient. I had one patient, despite all these, still coming in with a DVT, I think about 7 days or 8 days, a lady. So you are never out of the woods. I will never lower the bar for anticoagulants. I think, it definitely still plays a major role. So early mobilization, anticoagulants, using things like mechanical DVT shocks, all these things would have to be practiced.
Look at Slido. Crystal, there's still no question. You had a slide which showed it's not for all. Daycares, TKR is not for all. Maybe you want to show that slide again. But I also had some questions on who is suitable and who is actually not suitable. You mentioned something about sarcopenia.
Yes.
Sarcopenia. Maybe those like me who are a little bit lacking in knowledge of medical terms.
Okay, so every now and then, in fact, even now, I get patients who come in, even last week. I think after my initial news went out that I was doing daycare, knee replacement, some people thought I was a faith healer. So, people on wheelchairs coming and saying, you're going to make me walk. So, so I've had to manage with a lot of expectations and telling patients that, look, if you have been in a wheelchair for a year, then, even with a muscle sparing approach, I would reduce your weakness after surgery, but I can never make you stronger. So with any surgery, you are going to get 10-15% weaker. Now, if you're struggling to stand, or you're struggling to take a couple of steps for any reason, for spinal claudication, or just because you've got very weak muscle from prolonged immobilization, say you've had a stroke, or say you've really had bad knees and you've sort of been happy to sit in a wheelchair and not get up, and you can hardly get out of a wheelchair, then you would probably, I wouldn't advise you to do a knee replacement. I had a lady in January who came to see me 3 years ago prior to the pandemic, and I told her, look, I can change your life, do a knee replacement. And when she came back, I told her a totally different story. I said, I think you should reconsider this thing. And she was surprised. She said, why? I mean, the last time I came, you're convincing me to do it. I said, in the last 3 years, you've got significantly weaker. So pain and weakness are two mutual things. Of course, pain gives you a bit of weakness, but because you've had pain, you've had disused sarcopenia. So your muscles have actually shrunk because you hardly use the leg. And the reason why you're not using it is because of pain. So when I look at a patient now, I would tell them that, look, I don't think you should do it now. Maybe go for so many sessions of physio. I'll see you back in 3 months and see, and there are specific physios that you can do for patients with. Of course, you can't tell them to go and hike or, to run, but there are specific muscle strengthening that you can do for patients who have osteoarthritis. So I'll send them off to do that. So in case there's this lady whom I saw around about January, and I told her, and she came in with a family. She was quite adamant. She said, no, I think I want to get it done. Will I be able to stand after surgery? I said, you will be, but you will be struggling. And sure enough, we did the surgery. She struggled and hobbled for about 3 months, and subsequently got okay, and came and saw me about a month ago, and said she's finally better. Now, this brings me back to how knee replacements used to be in the old days, when we used to convince them, no, don't worry, you'll be okay, and then the first 3 months is a struggle. So when I told her, I said, see, this is exactly what I tried to tell you to do. Do your physio prior to a knee replacement. Get yourself in a better shape rather than to come, struggle after surgery. So the other question of whether it's everyone is fit for knee replacement are patients who have significant comorbidities, patients who have high HbA1cs, patients who have rheumatoid arthritis very poorly controlled, of course cardiac illness. Then these are not, patients who probably, not be good candidates to go under anesthesia. So age has not been a limiting factor. I've had patients who are 88 and 89. I had my cardiologist mother who was 80-something, who had a knee replacement at 88 or 89 and lived for another 4 years of good quality life, and who was happy when she saw me 2 years or 3 years after surgery and said that she should have done it earlier. So age is not a limiting factor, but multiple comorbidities, patients who are significantly weakened. Now, a textbook poor predictor of knee replacements are things like Parkinsonism, but I've done knee replacements in a few patients with Parkinson's. I've done partial knees, and they've been very happy. So this takes a lot of discussion with the family and with the patient, and managing expectations, and say, look, I think we will be, or we will not be, depending on the stage of the Parkinson's disease, or stage of usual risk stratification. Now, there are some things that I don't want to mention because I don't want insurance companies to say, oh, okay, this patient's but there are some patients, and I will tell them the risk. I tell them that, look, if I look back at my last 300 cases, you are the sort of person who would have this complication. I tell patients that. I say, look, in 200, I've had this many, and you fall in that category. So this is what you should do before you consider doing a knee replacement. And they are very grateful because they go away, they come back after a year and get knee replacement done. So no two people are alike, but a combination of comorbidities usually would get me a bit worried about actually touching them. So it's different if you're cancer surgery or cardiac surgery. You've got to just take the risk and bite the bullet and do it, but not when you're coming for improvement of lifestyle and send you home in a much worse situation than you are.
There was a question of Michael. So the first question was, can you explain further on the types of implants you use?
So for total knee replacement, we use a total knee, which means a knee replacement is actually a surface replacement. So we shave off the surface. Sorry, I don't have a model, but we shave off the surface of the femur and the tibia. We put a titanium base plate and a cobalt chrome C-shaped implant for the femur. Now, for a total knee replacement in the true sense of the word would include patella replacement, but I rarely do patella replacements in Malaysia because you need a patella of at least 22 millimeters to replace, because you're going to shave off about 8 millimeters of the patella. So most Malaysians, especially females, have patellas measured 19 and 18. So that would be a big risk if you shave off half and you leave about 10 and then drill holes in them. That would be one of the predictors of early failure. So rarely do we do that, but that doesn't really reduce the quality of the surgery. So yes, that's basically a knee replacement. So femur tibia component.
What are they made of?
Titanium and cobalt chrome.
The modern implant for the life.
Okay, longevity. So what I tell patients is it's a statistic. It's not an absolute number. So if I did 100 knee replacements in 60-year-olds with low BMI, with moderate activities. Maybe at about 10 years from today's studies, I would expect about 88 to 90% to still be okay, to still survive 10 years, which means that at 5 years survivorship, probably about 95%. So 5 would have failed before 5 years for reasons like maybe infections or loosening. Though in my own numbers, the numbers are far less than that at 5 years. At 20 years, probably something like 65 to 70%. So we still see patients at 20 years and 22 years having their knees in and absolutely pristine. Nothing that needs to be. So the predictors are patients who are heavier, patients who are younger, who are more active, patients who are poor quality bone. So these will all preclude to probably earlier failure rather than late failure. But if you take a cohort of 6-year-olds, BMI 25 to 32, moderate activities like normal activities are no running, hiking, jumping, they would probably last 85 to 90% at 10 years.
The second question there, does insurance cover robotic knee surgery?
I think insurance doesn't cover most things, which insurance considers robotic knees to be experimental, but I'm just afraid that some insurance agents listening to me.
What about your day surgery? I mean, these patients insurance cover this.
So day surgery very interesting. So this lady whom we did was not someone who had a knee before. She was someone who knew another patient of mine who had a knee, and she was a cancer survivor. She had very little money left in the insurance. So she said, "Doctor, how is it? How can you reduce it?" So around about this time, Trish, our previous CEO, had got Home Connect ready, and so everything on board. So I asked she and her husband, husband very involved in her care. So I said, "Where do you live?" USA. So I said, I'm doing this daycare thing. There is a possibility that she might be okay for it, and we will try to get the insurance to cover that. They said, "Well, if you can get the insurance to cover it and reduce the cost," because she had about 15,000 left, so then they would be happy. And she too was someone who really didn't like staying in the hospital. She spent a lot of her time in the hospital, and she really didn't. So I told her, "Okay, don't get too excited. I will admit you as inpatient. You don't go to the daycare ward, because if you send her to the daycare ward, we don't even know whether we can send you home. What if you have vomiting or you have anything or bleeding or whatever?" So we sent her to the ward, and we actually asked the insurance company. So what we asked the insurance company is this: so if a patient stays overnight, I'm going to charge the patient for 2 inpatient consults. I'm going to see you in the morning and night. Then the next day, I'm going to see you again, right? And the nurses are going to see you in the morning. You're going to get your breakfast, and then you're going to pay for another day of stay. So if you take away all that, and my consult is 105 in the morning, and if they can convert that to one teleconsult, right, which is 20 ringgit cheaper, and have a home connect nurse to go home and see the patient only on day 1 post-op, morning 1 post-op. They say, absolutely not. We're not going to pay for this. Right? We don't pay for teleconsult, number 1. We don't pay for home nursing, number 2. So I spoke to Trish. Trish said, fine, she will waive home connect. And I said, I will waive the home consult just for this. So we did it, and we basically, so we charged the daycare, everything that we did into the insurance was significantly cheaper, and we did the rest. I mean, we didn't charge for the rest of the stuff. So they will pay, but they will not pay for but for daycare. So now we have packages where a single night stay or daycare, which comes to the same thing. So patients don't really need to pressure themselves to stay to go home on the same day. They just stay one night. Usually I get a lot of patients wanting to go home the next morning, especially the cash patients, because by next morning they have gone through one night, they've woken up without pain, they have walked to the toilet at night, walked to the toilet in the morning. Some of them have even climbed stairs in the evening or they try and test the next morning. So by 10 o'clock, I get the nurse calling me, the one day, doctor, your patient wants to go home, boleh ke? So I've had a lot of patients with a single night stay, despite the fact they only do their surgery in the afternoon. But now, done in the morning, and then, so they've got a full day to recover. So by 5, they've done most things. They're walking in the toilet, they're perfectly okay. So they decide whether they really want to push themselves and go home, or they can stay one night and go back the next day. It's about the same cost.
Yeah, I think that, I hope eventually it will be worked out, and if insurance gets the number, I think.
So daycare is definitely probably for about less than 10% of people. And I think that's not going to change in the next 20 years. And that's not, even in Europe, they are only for a very, very small number of patients. But I think the more important thing to be celebrated is the fact that we've arrived in a point where, last time, zero knee replacement, epidural, 2 days later, epidural out, patient still screaming in pain, not able to walk, and then he still can't bend because so much of pain. Till we've got to a point where almost consistently we've got patients who can bend their knee, outside after about 80, 90 degrees, and who can get up by the evening. I think about 70, 80% can get up by the evening, go to the toilet, and almost 100% by the next morning. So I think that is more important than actually saying that, I want to do daycare. I don't think I think the achievement is actually getting to reduce their pain and improve their outcomes, their initial outcomes with these protocols.
Yeah, I think there have been no more questions. So what we will do is show you what everybody wants to see, which is the claiming the CBD point. Okay, so thank you all for being patient and watching the presentation by Dr. Siva, and I hope you've been educated as well as entertained as I have been. And this is the QR code for CBD point. Okay, so please scan with your MMA app. Siva, there's one last question. Somebody just popped it up.
Okay.
What percentage of patients bilateral TKR?
Percentage of patients for bilateral. Okay, so when patients request for bilateral, I usually send them off to see a cardiologist, get them to do a minimum of a low-glutamine stress echo, and whatever else the cardiologist feels they need to do. So that's very important. So the cardiologist gives me a go-ahead, then I would tell patients to do, I do them staged. So I don't do both. I don't get 2 sessions and do them together. I do one, reassess the patient after one, and go on to the second. I think I've had about 50, 60 last patients. I've never had to abort the procedure because prior to surgery, with the cardiologist seeing the patient, we picked up a few patients who were not fit for even a haircut. But thankfully, with very stringent pre-op assessment, we have been successful in doing all of them without actually having to abort after the birthday. I sometimes override patients' decisions. When patients say, I want to do both together, I would tell them no. And sometimes when patient says, I want to do one at a time, I would suggest doing both together. So I always try to have the final say based on my assessment of the patient. But so far, I've not had bilateral patients who had to abort, and most of them have been walking at least at worst by 48 hours, and most of them have been able to stand up on the day after surgery with muscle sparing approaches.
So minority, but they do.
Minority, but they're small things.
Thanks.
Okay, thanks.
Yeah. No other questions. So I hope you all got your CBD point. You can also, if you joined us late, this video will be posted on our YouTube channel. Please, if you have not, please subscribe to our YouTube channel so that you will be stay informed whenever we go live. We go live almost every month, and all our sessions have educational material, and you can claim DVD points at the end of it. Okay, so please do subscribe to the channel, and if you enjoyed the content, please like the video so that the YouTube algorithm will help popularize the video. So thank you all once again. I'm going to end the broadcast, but the QR code will still be valid for up to an hour or so. So feel free to scan, and have a good weekend, everyone. Bye.
All right. Thanks, Alan.